Good morning. Today's topic is patellar subluxation and management. Patellar subluxation is a partial dislocation of the kneecap patella. It is also known as patellar instability or kneecap instability. Symptoms: buckling, catching, locking of the knee, slipping of the kneecap to the outside of the knee, pain after extended sitting, pain in the front of the knee that worsens with activity, popping and cracking in the knee, stiffness or swelling of the knee. Causes: any extreme activity or contact sport can cause patellar subluxation. Patellar subluxations and dislocation mainly affect young and active people, especially between age of 10 to 20 years. For most first-time injuries occur during sports. After initial injury, the chances of the second dislocation are very high. Risk factors: general factors, ligamentous laxity as in Ehlers-Danlos syndrome, previous patellar instability event, measurable malalignment syndrome in which the fear is femoral anteversion, genu valgum and external tibial torsion. Anatomical factors include osseous patella alta, trochlear dysplasia, excessive lateral patellar tilt, lateral femoral condyle hypoplasia. Muscular factors include dysplastic vastus medialis oblique muscle, overpull of lateral structure, iliotibial band and vastus lateralis involvement. Diagnostic test is the patellar apprehension test and the patellar compression test. In the patellar apprehension test, the patient is supine with their feet in knee extension. The therapist slowly and moderately applies a pressure on the middle aspect of the patella, moving it to the lateral. And if there is an apprehension when you move it to the lateral side, away from the pressure, it's a positive sign. Presentation: symptoms: complaining of instability and anterior knee pain. Physical examination: acute dislocation usually associated with large hematrosis, medial side tenderness, absence of swelling supporting ligamentous laxity and habitual dislocation mechanism, increase in passive patellar translation, patellar apprehension, increased Q angle, the J sign, that is excessive lateral translation in the extension which pop into groove as patella engages trochlear early inflection, and associated patella alta. Management of pain mainly is through physical therapy, lifestyle modification, medicines and nerve blocks. The common exercises: mini squats with TheraBand for strength retraining. Stand with your feet hip wide apart with a resistant band around your thigh just above your knee. Keep your weight on your heels. Lower your pelvis down and back to a shallow squat, bending to 60 degrees. Keep the pressure on the band by pushing your thighs out, and this works the gluteal muscles. To strengthen and to protect. To return, push with your pelvis up as you straighten your knees. Target muscle: the gluteus, quadriceps and hamstrings. Side-lying hip abduction. Lying on your side with resistant band around your ankles. Your bottom leg bent to help you keep stable and your top leg should be straight and in line with the body. Lift the top leg diagonally up and back while keeping your pelvis still. You should feel your gluteal work and your muscles on the outside of the buttocks. Slowly lower your leg down. Target gluteus medius and minimus. Resistant hip abduction, standing with the TheraBand. Stand on one leg with the band tied around the other ankle and stabilize it as it on a table leg. Keeping upright straight through the body, pull the band inwards across your body. You can alternate by pulling the band in front of your body and behind too. Slowly return the band to the side and repeat. The target muscle: hip abductors. You can do stretches 3 sets of 30 seconds each for the quadriceps, the hamstrings and the gastrosoleus as shown in the picture below. The next is hamstring curls, which can be done in standing or in supine. In level platform, progress to unstable platform for added strengthening. The inner end range knee extension: keep a towel below your knee and slowly raise your feet up from the floor to a straight line. The target muscle is the quadriceps. Next is bridging with a TheraBand. Lie on your back, knees bent up to 60 degrees, tilt your pelvis backwards, flatten your back and lift your backbone off the table. Feel your hamstrings and the back of the thighs as well as your gluteus curl back down. The hamstrings and gluteus are targeted. Next is the kinesiotaping method for stabilizing. And then the last procedure is surgical reconstruction, the medial patellofemoral ligament reconstruction. It is an arthroscopic surgery involving two small incisions. In this process, the ligament is reconstructed using a small piece of tendon taken from your own hamstring muscle or from a donor, and you can usually return home the same day wearing a brace to stabilize your knee. This brace helps you keep the leg straight while walking, and it is worn for 6 weeks. The other surgical process is the arthroscopic lateral release. It's a minimally invasive surgery to correct the excessive patellar tilt. It involves cutting through the tight retinaculum so that the kneecap is slipped properly into the groove, thereby restoring the normal alignment. Thank you very much.